This talk I've given before. Actually, we had different topics, and they thought that this could be the most relevant talk in Canada. People are interested in this topic. It's about end of life. It's not just about MAID, but I mean it's related to what that is. You know what MAID is, right? The Canadians are kind of more or less aware of that. But it's actually a frame in the more general perspective of all the major end-of-life decisions that we tend to come across. And sometimes we are a little bit confused because it is not that simple, right? So euthanasia is one thing, but sometimes also there's a bit confusion of what exactly is euthanasia, and how is that different from, for example, assisted suicide, what that is, what is MAID. And then there are other things that are kind of very borderline. We call that overzealous treatments or therapeutic obstinacy. Basically, that's kind of saying, like at the end of life, should we go all the way and keep going on and on and on, and when do we stop? And if we stop, is it euthanasia? So there's a little bit of confusion and vague area between one and the other, right? So how do you distinguish one from the other, and when does it become, at least from the Catholic perspective, acceptable or even obligatory to stop the treatment? And on the other hand, when does it become euthanasia, when you should not? I guess we are against euthanasia, and it's explicit, definition. And the more common thing that you see is DNRs, right? So when you go to the hospital, sometimes the staff, the doctors usually come in, or nurses even, would come and ask you if you want DNR, or they would highly recommend DNR, right? And then you were wondering, some people would, those who are not familiar with the medical jargon, they would be confused. It's like, does it mean euthanasia? Does it mean that, I'm going to, allow my family or members or whatever to die if I don't sign the DNR? Is it wrong to sign the DNR, do not resuscitate order? So that's another question that people come across a lot, right? And then there is the question of treatments, right? Do you always have to get treated for a condition? Most commonly is usually serious conditions, for example, cancer, right? When can you say no? Is it wrong to say no? Okay, I was just talking to this table. The father had a fall, and basically the people in the healthcare wanted him to go to the hospital, and that was actually not a good thing because he actually aspirated in the hospital and died, right, in some way. So can you say, I don't want to go to the hospital, and is that okay to not go to the hospital and refuse treatment? Or if you go to the hospital, you start the treatment, and then you can say, can I stop the treatment because it's kind of like it's doing more harm than good, right? Even though the doctors say that it would extend your life, but you say, well, actually, I'd rather take it easy and then just kind of go naturally rather than getting aggressive treatments or the operation, even hip operation, things simple like that, right? So when is it that you can say yes, we can stop, and when can you say you shouldn't stop, right? So those are difficult decisions, right? I'm sure you all face that. And then there's a living will. Depends on the country, okay? Sometimes you're saying that, okay, now I'm still healthy, but in the future, I want to have an advanced directive, someone to decide on my behalf. Either a person or a piece of paper, which is colloquially known as a living will. right, or the advanced directives. So that I write it out and say that if in the future I find myself in this situation, I want this to be done to me and I don't want this to be done to me, that kind of thing. So you basically spell out more or less what the healthcare professionals, or even could be your family members, tell the doctors, or you actually, I mean, there are different ways to doing that, but it's more like you're anticipating, okay, that you find yourself in a future situation and you don't, usually it's most likely you don't want everything to be done to you. You don't want to be stuck on a ventilator, let's say, right? So that kind of thing. So how do you go about writing that will, and if it is ethically advised to do that, and so on, right? After that, there is other 2 points. One is the palliative care. I think this is what is that? Okay, palliation, maybe you know about that, right? So this a kind of care that is given to people who are in end-stage disease, right? And then so that they feel comfortable to spend the last days of their lives. And then there is this, which I will spend a lot on, proportionality, right? Proportionality. So basically, I'm repeating myself, when not to start and when to stop, okay? So this is a common question, especially when your condition has become more serious, chemotherapy, hydration, getting IV, or getting food, okay, artificial feeding, getting food through a tube, we call a PEG tube, epigastric tube, right? So they make a hole in your stomach, and so you can actually get a tube and feed yourself when you cannot feed yourself or when you cannot swallow. Or sometimes it's not a question of whether you can or not, but it's more like it's just so much more complicated to feed you, for example, that they prefer, nurses or doctors prefer to give you a tube, because that way the nurse can just kind of feed you with a syringe rather than feed you by mouth, which could take half an hour, right? So nurses' time are resources that, it's difficult. Then there's painkillers, right? When can you take painkillers? And there's a question about painkillers, you getting addicted to it, right? Painkillers is a problem. And there used to be a question about whether painkillers can actually cause death, right? Even on high dose morphine, can that cause death? And so that's why a lot of places, less so today, but 20, 30 years ago, there was a big concern that if you give painkillers and the patient dies from the painkillers, then it's kind of like killing the patient, right? So a type of euthanasia. So people are worried about that. Quality of life, right? So basically, that's another issue that comes into discussion, right? When do you want to extend life, undergo treatment or not? Whether it can improve your living condition, the quality of your living. So, and how do you measure that? And how does that enter into the calculation of whether you want to continue a treatment, start a treatment, continue a treatment, or discontinue a treatment, right? Those are questions that we all face, right? And whether that enters into the calculation or not, right? And then basically intubation, extubation, right? When should you go on the ventilator? Okay, intubate. And if you're intubated, when can you pull the plug or extubate, right? And is it wrong to extubate, to discontinue the ventilator, right? And when is it okay and when is it not okay? I mean, a lot more questions than answers right now, right? So I want to introduce an important concept in all these considerations. And the term is proportionality. Proportionality, okay? And it's basically if you can get this principle of proportionality, then you probably can answer all these questions that I just raised, okay? To more or less, right? Proportionality. What is proportionality? Proportionality, in the old days, they call it, actually there's another term for it. Now, they've changed terminology for a reason. Before it was called ordinary and extraordinary means of any treatment or any intervention, okay? Ordinary and extraordinary. Now, the preferred term is proportionate and disproportionate. Okay, so before, proportionate would actually what they would call ordinary, and disproportionate is what they would say call extraordinary in the past. But that causes confusion. The word of ordinary and extraordinary causes confusion because for historical reasons, it's usually has different connotations, right? Ordinary means just common things. Extraordinary things means there is something going on that is like out of the ordinary. It means usually more like intervention that is not ordinary, right? So it's a little bit confusing. So the term has been discarded, and they prefer to use the word proportionate and disproportionate. Okay. So what is proportionate and what is disproportionate has to do with a particular situation, right? So basically, in the sense of, okay, in this case, in this person, in his environment, okay, is this treatment proportionate or disproportionate to the betterment of this person's health condition, right? So proportionate is both a evaluation that is objective, but also you take into account the subjective elements. So most normal thing, like, I mean, there are many examples. I give you the most common one is basically, okay, you discover that you have cancer, okay? Should I undergo, I mean, this is very common, should I undergo chemotherapy or surgery or radiation therapy or whatever, right? So the doctors give you objectively all these different treatment possibilities, right? And risks and the benefits, right? And then you make kind of a calculation, right? The more aggressive you are, the chance of you being cured is higher, but then the side effects are higher, right? So that's usually the case. And so it's objective in the sense that these are numbers from scientific studies, and so you basically make that kind of objective calculation, right? Now, there's also a subjective element to that, in the sense that it could be for that person what is acceptable could be quite different. Like, for example, it has to do with, okay, this chemotherapy, is it going to cause you a lot of discomfort, side effects, nausea? I mean, I'm going to lose hair. I'm going to, I'd be in a lot of pain, right? So subjectively, it's different for everyone. Some people would say that, oh, for me, the cure is most important, right? I would, even if it is a 5% chance of curing, I'm going all the way, do everything possible. Right? And then the person will say, oh, even the cure is 80%, but this is going to cause me to lose my hair, I will look ugly. And for me, that's unacceptable, right? And it's okay, it's okay. There's no one rule that everyone has to kind of say, you have to do it, right? So both the objective reality and subjective evaluation is important, okay? And so, and that's why sometimes it's hard for us to come up with one answer, because actually the thing about ethics is that sometimes the system wants you to have a clear-cut algorithm, so okay, yes or no. It's not that simple because people are different, right? There are many, subjective elements, right? Depends on how old you are, what's your ethnic background, what's your economical situation. In Canada, it's less of a problem because we have universal health care. In other places, cost is a problem, right? Am I willing to spend all that income, all the family, resources to cure me when I'm 90 years old, and I'd rather not be cured, and so the money could be left for education of my grandchildren, for example, right? So that's a valid point, right? Economy is a valid point. And in some places it is. It should be taken into consideration, right? So age is definitely a consideration, right? And so on, right? If you're older, you say, well, I'm ready to go. The treatment is too aggressive. It might give me another 6 months. But what 6 months? I'd rather enjoy my 6 months than 6 months of suffering, right? That's a valid calculation as well, right? So basically, so we have all these things that are evaluated to see if it is proportionate or disproportionate to you, to the patient, right? So he can, ultimately it's the decision of the patient, because sometimes we feel, we tell, Mom, this is good, this is easy, you just take the chemo, 6 months, you're cured. But then, you're not taking the chemo, she's taking the chemo, and she's the one who has to go through the complications, right? And she said, no, I'm not gonna, that's too much for me, I really don't want that, right? So that's also quite important, right? So subjectively, the burden, costs and benefits, financial, psychological, spiritual needs. Sometimes, this principle, okay, I give you some background. Okay, it came, before they call it ordinary, extraordinary, it came from the 16th century. There is a Spanish moralist called Francisco de Vitoria, and he basically formulated this principle at that time. And he gives some example. For example, in those days, he gave 2 examples, right, of proportionality. So one is a soldier, okay, he basically has an injury at war. In those days, no antibiotics. So he has a gangrenous foot, right? And then the treatment at that time was amputation, right? But they didn't have anesthesia either, right? So it would be a very painful operation and to take off his leg, right? So objectively, you could say, well, you can save your life, right? And so the doctors would recommend it because that's the only way you can save your life. But from the soldier's perspective, is like, can I bear with the pain, right? and am I going to live without a leg for the rest of my life? So he can make that kind of calculation and said, for me, in my case, I'd rather die than to undergo the pain, right, of the operation and to live without a leg for the rest of my life. I mean, he could say that, right? Or he could say, no, life is better, even though it's a bit of pain, but it's only a few hours, and it's better to have one leg and live on because I have to do whatever I have to do. I mean, it depends on his life project. I still have my life ahead of me, I have my wife to go back to, and so on, right? So, depends on that person, right? He's only the one who can make that kind of calculation, whether it's proportionate or not to his situation. Another example that he gave was basically a religious sister had to undergo some kind of chorological examination, right? And in those days, it was very embarrassing, right, for a nun to undergo that kind of examination. So even though medically it was no big deal, but for her and her condition, psychologically, spiritually speaking, she felt very much kind of like a violation of her virginity and all that, right? All that implication, and she actually could refuse it based on the way she's living out her religious, consecration, her virginity, right? For her, that was a very important thing. So, those were the two examples he gave, right? That the subjective element, because of the background or whatever it is, could actually influence whether a certain intervention is considered proportionate or disproportionate. Okay? Here, on the objective side, the only thing that the church has done, I think, is good in some way. It says food and water is always ordinary or proportionate, because it is not really a treatment, right? It is sustenance, right? Because without food and water, you cannot survive. But then air or ventilation is not under there, right? It's not objectively always, right? But even then, food and water could be disproportionate in some extreme cases, right? Usually it isn't, but in some cases it could be, right? So once we have clear about whether something is proportionate or disproportionate in this particular condition, right, for that particular patient, then we come into this principle. If it is something proportionate, okay, considered proportionate, then you should do it. You're kind of obliged to do it, always obligatory. If it is considered something disproportionate, then it's optional. You can do it, and it's okay, and you can decide not to do it, and that's okay too. Okay? If it is disproportionate. So, for example, let's say you didn't live in Canada, or you live in somewhere else, or even if you live in Canada, right, there is, okay, you have a cancer. And then they say, okay, all the treatments are like this, and then you've undergone different treatments, and there is basically, you're losing hope. It's not curing cancer, and then there is this one treatment that is very unlikely to be successful, and it's very expensive, and you have to go, I don't know, maybe let's say you go to Switzerland for it, right? It costs millions of dollars. And so it's, I would say, objectively disproportionate, right? The cost and benefits doesn't really come out, right? Because the chance of curing is low, and the cost implied in getting this treatment financially, economically, and so on, is quite high. So it is disproportionate treatment, right, for you to undergo this treatment. But you can also do it. It's not wrong to pursue it. Okay, no, it's not wrong to pursue a disproportionate treatment. But it's not wrong to forego it either, right? So that's how you apply that principle of proportionality. Okay, so this is the most important slide. Okay, okay. Now you can apply it to all the different scenarios I gave you at the beginning. Okay, so here is basically you apply this principle to treatments, right? So actually, this is from a church document. It's saying the same thing that I'm saying, right? So if you have a treatment offered to you, right, can you refuse it? Be it ventilation, be it antibiotics, be it surgery. Do you have to undergo this, right? If it is proportionate, you should. If it is disproportionate, you could, or you might want to forego it, right? So that's basically what it says. It's not always obligatory they undergo every treatment proposed to you by a doctor, right? So especially here, it talks about disproportionate treatments, right? You can actually let go, right? Because sometimes you see this a little bit more in ICU, right? Someone who is in ICU has been there for a month or 2 months, and they're already intubated, they're in coma, they're not getting better, and the chance of them getting out of it is quite low. So in some way you say, okay, the prospect of this patient prognosis is not good. And then you can say that this treatment that the patient is receiving is disproportionate, right? Medically speaking, objectively speaking, and also subjectively you can say that, well, the chance of him coming out of it is low. So you can say, okay, since this is disproportionate, apply the rule is that you can forego, you can withdraw, okay, the treatment, and that's not wrong. Or you could even say not initiate, well, the treatment if the patient before he came into ICU already is in this stage of kind of like uncertainty. We think that this patient has no prospect of recovering. You don't have to start, right? You don't have to start. And that sometimes is okay. And sometimes it's even, or I would say, wrong here in this case when it talks about overzealous treatment. It's actually wrong to continue, okay, a certain treatment when it's hopeless, kind of like when it's futile care. Basically giving a treatment, the patient is not benefiting, and just keeping that patient in life, right? So it becomes almost like futile care, or sometimes they call it therapeutic obstinacy. So you're obstinate, you want to keep going on because you don't want to let go. And a lot of times, actually, from the little experience I had from way back in medical years, there is some unresolved family issues there, right? The most common thing I remember the doctors talking about it is usually the family feels guilty because they've neglected the care of the elderly for so many years, and they don't want to let go because there's this easy way to say, oh, I've done something, right? And I've maintained that person in life because they feel guilty about the neglect for all these years, and they can dump it all on the medical personnel. And so it's really, for the medical personnel. It's like taking him a bed of ICU and you don't want to let go, but there's no chance of this patient coming out. I mean, they could be in that condition for 6 months and so on, and they're still not willing to let go, right? And that's really like selfish in some way, right? They just kind of like holding on to something because they want to say that I've done something, or that I've done something by not doing anything. so it's something that sometimes you see, right? So this is therapeutic obstinacy, basically saying that sometimes it is actually advised, it's actually, I would say, a disproportionate care. In this case, okay, in certain cases, it's actually wrong to continue. Right? It's wrong to continue a disproportionate care when there is no chance of the patient benefiting from it. So what you're doing is prolonging the death. You're not prolonging life, you're prolonging the death, right? So that you're not actually benefiting the patient at all. DNR orders, right? Let's see if I have to, okay, DNR orders. So basically, DNR orders, once we have this thing very clear about proportionality, okay, DNR orders is usually done when the patient is admitted, right? The thing about DNR orders, you have to realize, if a patient does not have a DNR order and in the hospital and has undergone an arrest, a cardiac arrest, usually, then the doctors, by law, are obliged to do everything possible to save that patient's life, right? Intubation, ICU, everything, right? So that's resuscitation is basically the norm. So unless you have this order in place, you do everything. I mean, there's no, kind of do a little bit, no, there's no little bit. You just kind of resuscitate, save the patient's life to the best of your ability, right? That's resuscitation. So basically, if some patient goes in hospital already in some kind of end-stage disease or very old, whatever, and the doctors usually approach you and saying that, do you really want, okay, to do that type of resuscitation to maintain the patient in life, even if he or she goes into, right, a coma or an arrest, right? So that's kind of like the thing. So you would say, I mean, you could have the discussion with the patient and say that if I find myself in this, should I let go, okay, or should I do everything? So usually, I mean, if you are younger, healthier, you don't expect, it's just some kind of operation that is not life-threatening and you have no underlying condition, usually you would not have a DNR. But if the doctors approach you saying that, well, okay, you're kind of older, you have some underlying conditions, you have cancer, you have Alzheimer's, whatever, right? Then they could ask you, say, okay, you have to make that kind of decision usually with the patient to not resuscitate if anything were to take place, right? So that's the DNR order. And once again, it goes back to proportionate and disproportionate, right? But with disproportionate, you can still ask for that as long as it doesn't pass into therapeutic obstinacy. So basically here it's kind of like, it's not wrong to do resuscitation, even though it's disproportionate. You can say, okay, I want everything done. It could be proportionate even, right? So basically, let's say, I mean, there are cases, I mean, theoretical cases, right? So I want to see, for example, my son, he lives very far away, he's trying to come in, I want to see him last time, right? He's coming, he's on his way, but he's not here yet, right? So the patient can say, well, I want to be there when he comes, so don't let me die yet, right? It could happen, right? So there could be spiritual reasons, right? It could be something like, I want to make up, right, with this person before I die. And so that's good enough. I mean, proportionately, you can say, well, even though I don't have much to live, but I have this to live for. Right? I want to make that final goodbye. And that's okay. That's okay. So I mean, once again, situations are not just medical, but also personal, spiritual, and those should be respected as well. Now, euthanasia, we go into a different category. Euthanasia is basically defined as whatever its motives and means. Direct euthanasia consists in putting the end to the lives of the handicapped, sick, or dying person. Okay, it's an act or mission of which by itself or by intention causes death in order to eliminate suffering, okay, of the person. So basically, by act or mission, you want intentionally to end the life of the person so that he doesn't suffer anymore. Okay, that's the definition of euthanasia, right? So once again, it doesn't have to be that, okay, the patient is dying or not, okay? The patient is suffering, okay? Maybe he's dying, but he's not dying fast enough, because otherwise if he's dying, you can just let nature take its course and the patient will die. But the reason you want to hasten the death, right, by an act or by an omission, it's important. An act meaning that you give something to the patient so that the patient die. So it could be usually drugs, right, morphine or whatever, drugs. I won't tell you what works best. So you basically give it to the patient so he dies right away, or withdraw something, okay, stop giving the patient liquids or food so that the patient would die, right? So by act or mission, with the intention to end the patient's life because the patient is not dying fast enough and is usually some kind of suffering, either physical or moral, right? Okay, and that's euthanasia by definition. And it is, at least in the Catechism, talks about wrong because it is a type of homicide, right? Type of homicide. You're killing the other element that usually comes with it is that if it is done by the patient himself, it is suicide, right? If it is done by the patient himself with the aid of the healthcare professionals, it is assisted suicide. So the doctors won't do it. The doctors will give you the means to do it. Okay, I'll give you the drugs, you push the button, right? That kind of thing. So that's assisted suicide. If the doctors do it, it is euthanasia, right? And it could be the doctors doing it in consultation with the patient. So basically, doctor taking order from the patient. So it's a voluntary euthanasia. If the doctors decide without consulting the patient, then it's involuntary euthanasia. Now, whether suffering enters or not into euthanasia is another big topic. Whether you need to have suffering and what kind of suffering constitutes a justification for ending the life, right? So once again, most of the time, it is a physical suffering, usually pain or whatever. Could it be non-physical suffering? Could be, I mean, nowadays they talk about psychological suffering or even existential suffering, right? So, so now it becomes more kind of nuanced, right? So now you can talk about, I mean, it's easier to understand that through the analysis of suicide. When is suicide, well, okay, when should we prevent people from suiciding, right? So usually people commit suicide because they have some kind of suffering, and they would say, okay, life is not worth living anymore, and I'm going to kill myself by whatever means they find, right? And so basically, the reason behind that there usually is some kind of suffering. It could be physical, right? I'm paralyzed, I'm undergoing end-stage Alzheimer. Well, I mean, that's more difficult because then they're not like able to decide on their own, but some kind of, let's say, Lou Gehrig disease or some kind of ALS. So I'm becoming less capable of doing things I want to do, and so on, right? It could be people commit suicide sometimes for psychological reasons. I'm depressed, right? Or it could be just existential. I find no meaning in my life. I mean, that is actually very similar, but it's not identical. Some people may not have depression and still say that my life is not worth living, right? So all these suffering, okay, can push someone to decide, and it could also be a psychological condition. I mean, there are different psychological conditions that make the person want to commit suicide, right? It could be schizophrenia, it could be different things, right? It may not even be depression. The most common thing is depression, right? Usually, so basically, when someone tries to commit suicide, you see someone trying to jump off the bridge, the natural reaction is like, the patient is sick. There's something wrong with him. We should save that person from killing himself or herself, right? So that's the natural reaction. And then you can try to say, okay, figure this out later on, right? So once again, euthanasia, the whole debate goes into that recently, right? When MAID originally was passed as law, they were very stringent about that, it being a medical condition that is causing some kind of suffering, right? And so it's a physical suffering is somehow allowed. Later on they say, well, people could be suffering without physical pain and so on. And then even though they could be suffering even without any medical condition, just because they are unhappy, right? And it could be psychological, it could be just depression, or just like life is such a burden, I don't want it anymore. So basically that's kind of like the slippery slope, right? So now I think in Canada that's being blocked, the last part about existential psychological suffering, except for Quebec. But in the rest of Canada, that is not a rationale for euthanasia or MAID, right? So anyway, those are, I'm not sure you answered the question, but that's more or less the situation here. So we went into the next question about, in some way, medical assistance in dying, MAID. That was passed in 2016 and I think renewed recently, 21, if I remember correctly. And then, so basically the debate now has moved to how do you, it's more like a procedural thing, right? How do you allow this? What are the fail check system? Who can offer it? And so on, right? But basically it is, MAID is euthanasia because the intention is that the patient should die. You should voluntary euthanasia. Patient says, I want to die. And the reasons is usually they have to make the application, justify the thing, and then the doctor has to do it. So it's basically a medical intervention, right? So it is a type of assisted suicide. So doctor is helping the patient to die, right? The recent debate is whether psychological and existential suffering would be allowed. And in some countries in Europe, the question is also about age, right? Who can decide, right? Do you have to be 18 and above to make your decisions, or can it be applied even if you're younger, right? In Holland, I think they allow up to age 12-year-old could decide if they could apply for this. Okay. The one question that I think is related to the question of end of life is the question of dignity. And it's been, I think, misunderstood a bit, the whole notion of dignity, because some people would say, okay, my life is not worth living anymore because I don't have any dignity anymore, right? Because for example, I can't care for myself, I can't clean myself, I can't go to the bathroom myself, I'm in diapers. That's a life not worth living, right? Especially those who are basically have to, there is a kind of suffering there, even though I'm not dying. I feel that my life is not worth living, it has lost its dignity, right? So basically there are movements, actually a lot of the pro-euthanasia movements have used that word, dignity, dying with dignity. I want to die with dignity because it's no longer worth it. So here is a complicated issue philosophically speaking. Dignity is a loaded word, right? Loaded word. And I think there are different people who talk about different types of dignity. And I think we as Christians, usually we talk about a type of dignity that's more intrinsic, inherent to just being a human person. We talk about the image of God. So that dignity can never be taken away, right? Because it is inherent, it is there by the very fact that you're a human being, right? You have that dignity. Or sometimes they use the word, you have a soul, right? And then there are other types of dignity that are conferred on you, right? That you can fight for it or you could earn it, right? So basically those are dignities because you have some kind of excellence, right? You've won a prize for whatever, you play ping pong and you came number one, or you are a great scientist. So those are dignities that are conferred, right? And in between there's also dignity that are kind of like growing in you because you've achieved certain skills, certain abilities, certain things that would be recognized, right? And okay, the other two types of dignity could actually diminish as you get sick and old, right? And you can feel that you are no longer as dignified as you used to be. But that central core dignity, the inherent or ontological dignity, never goes away, right? And so that's at least from philosophical point of view, that distinction we need to make, right? That you are always worth it, right? Worth it, not in eyes of men, or your own eyes, but the eyes of God, right? Ultimately, that I guess in today's society, which is getting more secular, is much more difficult to explain, right? So basically, euthanasia is becoming more accepted in society because of this. Because we no longer accept this core dignity that we say is intrinsic, right, to everyone, that you cannot lose. And that basically is I guess is a type of secular mindset because the dimming of the presence of God in society actually will have all these impact on the practices of the people, right? Because if you are just like an animal, right? If your dog is suffering, put an end to the dog, because we would do that, right? Euthanize a dog for suffering. But why can't we do that to human beings who are more valuable than dogs? Because there's something else there, right? So that's what we're facing, right? Okay, the other points I think that are related to this is advance directives or living wills. The alternative that is power of attorney, that you could either write it down, how you want your life, to be ended when you cannot make the decision, right? So it's kind of like when you anticipate that you can no longer make the decision, you delegate that decision to a piece of paper or to someone else, right? So it's very important. It's a delegation of how you want people to treat you when you cannot no longer make that decision yourself. You want someone else to decide it on your behalf, not for you, on your behalf. Very important, on behalf, right? Because that's not power of attorney, because if you delegate it to someone so that he can decide or she can decide for you, then that's not the idea, right? So your decision is being respected this way. So living wills is a written document, and it depends on the country and place. It could have certain legal authority, how you want it to end in a written way. The problem with living will or advance directives is that it's sometimes open to interpretation, and who does interpretation, and also you cannot foresee all the possible situations, right? So basically, it could still be a little bit, how should I say, does not really represent all the possible situations by which you would say, if I were there, I would make that decision this way, because we cannot anticipate everything. And it's just a human nature, right? I can say that now when I'm healthy, but when I'm there, I might change my mind. So it's not the best, right? Now, power of attorney is basically saying that I want someone to represent me and make that decision as if I were there, right? So that that person can represent my thought, my way of thinking. So you need to talk to someone, let that person speak on my behalf when I could no longer express my will. And that person should know me. Okay, you should talk to that person. Now, a lot of people make it their spouse or their siblings or whatever. It's actually, in my mind, a lot of people are saying that that's not the best, because they might not represent your desire, because their desire gets into it, and basically because if it is your spouse, okay, even though you have kind of explained to your spouse that in this situation, don't resuscitate me, it's hard for the spouse to do that, right? But if it is someone else who is more like a friend or someone who's kind of a close friend, it's easier, because he or she is trying to represent you in the way you think. Okay, so a power of attorney should ideally be not someone too close to you, right? A sibling or your spouse or your parent, okay? Because by nature, this is the power of attorney and not a substitution of your decision making, right? But a representation of what you would like. Now, there is a third alternative, the Catholic the National Catholic Bioethics Center in the United States. They actually propose a living will that's very simple. But basically, for those who are Catholics, they're saying that I adhere to the teaching of Catholic Church, and I just want my end-of-life decision to be done in conformance to church teaching, basically what I just said, right? So it's quite reasonable. It takes away all the different legal ambiguities, right? And so basically there is basically, okay, I follow that principle of proportionality in some way and apply it accordingly. So I would not have euthanasia. I would not have allow for therapeutic obstinacy. So I basically saying that if this is proportionate, then I should continue. If it is disproportionate, you can discontinue, right? So there is kind of like within that boundary of Catholic moral teaching is very clear set. So you can always get an ethicist involved, and so in some way it takes away all these uncertainties. This is what I usually propose to my students. So you can look this up. End-of-life planning form. I'm not sure how valid it is. I mean, all these also carry with it the legal ramifications and jurisdiction, and those I leave it to lawyers. So I don't know how that works in different countries. Now, there's also a question that related thing is palliative care. Palliative care is actually Canada is one of the first places to have initiated palliative care. So palliative care is a way to say, okay, if a patient is suffering, okay, physically or psychologically or even existentially, can we alleviate some of the suffering? So instead of giving them the way out by ending their life, so basically euthanasia is a way of ending suffering by ending the patient's life, right? Because if they kill the patient, then he doesn't suffer anymore, right? But the question is, can we do something to ameliorate the suffering, right? And so there is something called palliative care. And basically it depends on the country once again, the services that are being provided. They're not trying to cure the patient because it's usually end stage, right? And then you're trying to give them a lot of nice food, nice place to stay, nice music, company, games, whatever, keep them comfortable. Even you can give them painkillers, but in a way that is like whatever, proportionate to their to the suffering. So you try to find ways to make the last days comfortable, right? There were places that even make the hospital looks like an apartment, looks like your bedroom, right? So that you don't feel that you are in the hospital, right? That kind of thing. Obviously, quite expensive, and once again, it's unfortunately I don't know. Probably MAID is cheaper than palliative care. I'm not going to say more, get into trouble. So how much of that is really financially driven to end someone's life, right? Okay, painkillers at end-of-life care. I mentioned this before. It's usually in the old days, they were worried that if you give high-dose painkillers, you can shorten the life of a patient. Nowadays, they're less sure that this is actually, they've demonstrated it doesn't happen, right? So it's no longer a problem. But even way back then, they allowed that because you can apply what traditionally called the double effect doctrine, right? The principle of double effect is saying that my main intention is to alleviate the pain of the patient. There is an undesired effect which is present, but it's not what I want to do, which is shortening the life of the patient. So if you have two effects, so double effects, you can actually apply that principle saying that I'm not trying to cure a patient, I'm trying to stop the pain, right? Even though it might shorten the life of the patient, that's okay, right? So that's double effect for you. So in that case, in general, I mean, right now we're saying it's not a problem if you want to, alleviate pain. This is more controversial, palliative sedation. So basically, there are some cases where the patient's pain or suffering is so severe that no medications can really stop them from suffering. And so we basically sedate them, right? Sedate them meaning that they're falling asleep. So if you're falling asleep, then you don't feel the pain. You don't feel the suffering, right? So that's a proposal to the extreme, right? So basically there's also, but then some people are afraid that this could lead easily to euthanasia, right? Palliative sedation, because you sedate them more, and then they just move on. So this is more complicated. I'm just trying to let you know that I think it's not necessarily wrong to have this palliative sedation. You just have to be quite careful, as to why you're doing it, and if you are really trying to help the patient, but then they're not really conscious, and so that kind of thing, right? So it's more complicated an issue, ethically speaking, but also very expensive. So I don't know if they have that in Canada or not. I don't see that in the list of. If the doctors here can let me know if this is an option in Canada or not. But I know in some other places in Europe, they were talking about it. I know that this is very selective and very costly, okay? So that's it. This is the end of my talk. So if you can get this one take message, proportionality, okay? That's all. I think you can take this away as your principle that you can apply to all these end-of-life issues.